everyone, depending on where you are in Canada. Welcome to the first of our Breathe Change Policy series of 2024. My name's Jess Rogers. I'm the Vice President of Programs, Research and Public Affairs at the Lung Health Foundation. Thank you for everyone who has signed up for today's webinar. We'll give people a chance to log in here. So the first of our three-part series is called Building Respiratory Resilience, Partnership for Improved Care, and Funding for COPD. So we're going to have a good conversation today. We have people from across Canada, lots of different diverse perspectives that are attending today's webinar along with our panelists. We want to first off start by encouraging everyone to use the chat function within the Zoom call. We want to hear people's perspectives, your experiences, your comments, and of course your questions, because we are going to have opportunity to talk together and talk to our panelists. And you'll hear more about the Lung Health Foundation and why we do this work in a moment. Before we really dig in, we do want to pause and just have everyone reflect on the land in which you're currently on, whether you're at work, home, or other. The Lung Health Foundation's office in Toronto, Ontario, Canada, is located on the treaty lands and territory of the Mississauga of the Credit First Nation, as well as the traditional territory of the Huron-Wendat and the Haudenosaunee peoples. We acknowledge that this land, because it is important to remind ourselves that we are working on behalf of all Canadians, including Indigenous peoples who have been and continue to be negatively impacted by Canada's colonial history. It's impossible to have valuable conversations about lung health, including the one we're going to have today on COPD, in Canada without connecting these conversations to the harms done to Indigenous communities. To this day, Indigenous peoples in Canada face health disparities and poor lung health outcomes, and COPD is no exception. While we continue to learn, the Lung Health Foundation is committed to doing our part in reducing these health disparities and enhancing the healthcare system to meet the needs of Indigenous communities. We do encourage you to learn more about the land in which you work, live, and play, and just anchor yourself to that understanding as we go forward. So in terms of why we're here today, we want to start first by introducing you, or maybe reintroducing you to the Lung Health Foundation. You can go back a slide, Hasna, please. Thanks. Oh, back. That's forward. Still forward. Nope. Keep going back. Okay, while Hasna's doing that, I'll talk to you a little bit of who the Lung Health Foundation is. So Hasna, we're just going back to the Lung Health Foundation slide when you're able to get there, please. So the Lung Health Foundation was formerly the Ontario Lung Association. What we've really done is built from that legacy to become a national organization that truly is the leader in lung health. And we're the voice of people living with lung disease, but also the voice of Canadians, because we all have lungs. And we want to protect all Canadians and ensure that Canadians can breathe better. So that includes prevention. It includes when people have a lung health issue, lung disease, et cetera. And so we do that in a number of different ways. So first and foremost, we are always listening because we are the voice of people living with lung disease and having lung health issues. We want to ensure that we understand what the issues are, what the barriers are. It also includes working very closely with healthcare professionals and researchers to make sure that we're bringing all those perspectives together so that we truly understand the gaps, but also what can be done in them. So that's research and understanding what those needs are. From that, we then develop policy asks and determine what is it that we really should be asking the government and government agencies for, and how can we partner with them to do that really well. We do a lot of work in practice change. So that's working within the health system with healthcare professionals to say, what can we do? What tools can we implement? What education can we provide? What else can we support to really help advance lung health? We also work in delivering actual patient programs or client-facing programs. That's not always delivered by us, but some of our marquee programs that we deliver are things like virtual fitness for breath. So how do you allow people who have a chronic lung health condition, not just COPD, although in large part, many of the participants do have COPD, they get exercise, they get counseling, they get support, not just from us, but from the other people that attend and participate, so that they feel that they're supported and that they belong. Those are just a couple of examples of what we do as the Lung Health Foundation, thanks Hasna, to advance the health of Canadians. So in terms of policy forums and why we're here today, we talk a lot about advocating, but advocacy is only one part of it. We have to activate as well. We can talk a lot about what's needed, but we have to make sure we're part of that solution. So these policy forums are not, they don't live and breathe onto themselves. They are part of a journey that we're on. Part of the opportunity for you today is tell us what you think in terms of what's going on in the area of COPD or what would help you from whatever frame of reference you come from. So through these forums, like today's session, we're continuing our leadership role as the voice for Canadians to ensure that all of us do breathe easier. They are designed specifically to tackle some of the most urgent and pressing issues facing people living with lung disease and the healthcare system. They're pivotal to our work, as I've said, and so we are listening. Next slide. Thank you. So we don't want to go forward without first acknowledging that we could not do any of this without support. We are a health charity, and so we want to make sure that we can acknowledge the sponsors that have sponsored this policy series overall. And we'll just wait one moment here because I want to make sure that we do acknowledge our sponsors just to check in and see what's happening with the PowerPoint. Hasna, can you just let me know? Would it be better if someone else shared?
Sorry, I'm just experiencing some issues on my end. Just give me 1 second, and we'll have it up in a second. Sorry about that.
No problem. While you're doing that, let me introduce our panelists. And so what I'll ask is maybe if everyone can kind of come on camera. You don't have to unmute at this point, but then everyone can kind of see your faces, and we'll do that. That way we don't skip a beat, and we can thank our sponsors in a moment. So we have 4 panelists with us today. So first, Dr. Joshua Wald, who's trained in respirology at McMaster University and completed a fellowship at the Montreal Chest Institute in pulmonary rehabilitation and chronic disease management before returning to McMaster to begin his clinical practice at the Firestone Institute for Respiratory Health, where he currently leads the inpatient COPD service and co-leads the COPD post-discharge clinic. He is vice co-chair of the Canadian Thoracic Society Assembly on COPD Steering Committee. So that the Canadian Thoracic Society develops the guidelines for COPD, for those that are not familiar. And his interests clinically and research are in the area of pulmonary rehabilitation and comprehensive care for patients with COPD. So welcome, Dr. Wald. And then we have Dr. Maya de Souza, who completed her medical and respirology training in both Hamilton and Ottawa before settling in North Bay, Ontario with her husband and 2 children. She is a staff respirologist and internist at the West Nipissing General Hospital and an assistant professor for the Northern Ontario School of Medicine. Her professional interests include severe airways disease, so that's things like asthma and COPD, and promoting respiratory education to medical trainees and healthcare professionals. So welcome, Dr. de Souza. We have Dr. Dawn Bowdish, who is a professor at McMaster University, the Canada Research Chair in Aging and Immunity, and the Executive Director of the Firestone Institute of Respiratory Health. So the same place where Dr. Wald joins us from. She studies how age-associated inflammation alters monocyte and macrophage development and function, and how this ultimately increases susceptibility to respiratory infections. She can explain to us more what that means, while decreasing the effectiveness of vaccines for pneumonia and COVID-19. Her team also studies how the aging immune system and the microbiome interact and how this contributes to healthy or unhealthy aging. And not surprisingly, Dr. Bowdish is going to talk to us a little bit about long-term care and COPD during this talk. She also runs the preclinical studies and aging laboratory and is on the board of directors here at the Lung Health Foundation, where she helps us advocate to increase research funding for lung health. And then we have Mr. Scott Bailey, who is one of our Lung Health Foundation advocates. And Scott was most recently with us in Ottawa on our Federal Advocacy Day, where we were advocating for asks around COPD, among a number of our other areas. Scott is also an active participant in our Virtual Fitness for Breath program. And so he's here to give us a lot of perspective, not just from his experience, but from those that he knows because of the community that he is now part of. All right, perfect. Checking back in. Hasna, are we good?
Yep, all good.
Okay, wonderful. So before we dig in, let's pause and thank our sponsors. Again, these sponsors are contributing, they're partners with us really over time, but they're contributing in particular to this policy series, the first of which is this one. So thank you so much to our sponsors. Next slide, Hasna. Thank you. So just a few minutes to top line before I hand it over to Dr. Wald. For those that are not as familiar with COPD, it is underdiagnosed, it's misdiagnosed, and it's treatable. COPD symptoms, activity levels, quality of life can be improved at whatever level you are in the severity of your COPD. And we know this, the research is solid in this area. There's a lot that we already know in terms of how people with COPD, what they should be able to expect in terms of their quality of life and the care that they receive. The frequency and severity of exacerbation, so that's kind of like when the breathing is worse than usual, can be reduced. There are significant cost implications to the health system, certainly, and those are also well documented. And as I said, there's strong clinical and implementation evidence on how to address these gaps. And as we sort of top-lined in our land acknowledgement, there are also significant inequities in health for people living with COPD in particular. Next slide. So just a couple of numbers. COPD is the 5th leading cause of death in Canada, 3rd globally. So this is something that we all need to know more about, regardless of whether or not you have it. It affects a lot of people. I mean, it will continue to affect more and more Canadians, and you'll hear more about that. It is the #1 cause of hospitalizations in Canada, apart from giving birth. So that's something to think about, right? In terms of, are we really putting enough attention and resources behind something that affects 2 million Canadians and likely a million more, if not more than that are not even diagnosed. And imagine what their quality of life is like when they're not even diagnosed and not getting the benefit of the things that we know that work. From an economic standpoint, the cost of COPD is estimated by 2030 to rise to $9.5 billion per year. So it's not nothing. It's very important from all aspects of the issue. Next slide. And when you look specifically within Ontario, as the slide advances in a moment, if not, I can top line it. Thanks, Hasna. So I'm not going to go over each of these, but you can see pretty quickly that, that's Canada. Then when you zoom into Ontario and each province that is represented here, I'm sure the statistics are quite similar. This shows you what that utilization looks like. And when we think about a system where we have a crisis in primary care, we have emergency departments inundated, walk-in clinics inundated, challenges with hospital beds, it's important that we're providing the care that people need, where they need it, when they need it, so that we, like as a population and as a health system, are really prepared to address the issues that people are presenting with at hospital or otherwise that need more attention. Let's just put it that way. So when we look at the cost isn't everything, but it does give us a sense of when we're thinking from an advocacy and policy perspective, sometimes these messages are what actually sort of gets attention, right? And that's part of this. How do we open the door enough to get in and to start having the conversations around what solutions could look like? Next slide. So when we talk about what we're advocating for, this is about targeting investments where there are appropriate policies that can be put in place, awareness initiatives that can be put in place that will actually help people better manage and improve their quality of life and alleviate strain on the health system, including costs, right? Next slide. So I've already introduced our team of panelists. What we are going to do is dig in now. Josh is going to take it away from here. And you're going to hear real stories coming from these different perspectives. And as I said before, I'll be monitoring the chat. So please feel free to go in there and share anything that you would like to. It doesn't have to be a question. It can be your experience. It can be a comment. It can be some of your thoughts. And again, I'll be monitoring that as we go. So Dr. Wald, over to you.
Okay. Thank you so much, Jess, and thanks everyone for being here. I'll try to keep this didactic section short so that we have lots of time for discussion at the end. So very briefly, what is COPD? It's a chronic irreversible but treatable respiratory condition resulting in obstruction of the airways. It's often associated with emphysema and chronic bronchitis, which you can see visual representations of there on the slide. And the symptoms can include breathlessness, cough, and phlegm, along with a whole host of other symptoms, but those are the most common. And a key feature is that patients often experience exacerbations. So this is often what drives people to come to hospital, which you heard about what a huge impact that has on our healthcare system and how frequently these patients do end up in hospital. And it also is associated with lung function decline and increased risk of death over time. So exacerbations are one of the key risk factors for the disease worsening. If we can go on to the next slide. So to make a diagnosis of COPD, it's really important to have three things. So the patient should have some kind of symptoms, but these can, a lot of times, as we'll talk about, this can be missed. So, patients will say that, well, they feel breathless or they have cough, but they're a smoker and they're getting older and they attribute it to other things and they may miss the early symptoms of COPD. But if there's no symptoms at all, it's difficult to make a diagnosis. And then they should have a risk factor. So tobacco is the one we think of most often, but there's lots of other things. There's genetic factors, occupational exposures, and a lot of lines of work, indoor and outdoor pollution, and sometimes sort of risk factors related to lung development in childhood that can also put you at risk. And then most important, or key here is that you need to have spirometry to confirm the diagnosis. And as we'll talk about, this can be a sticking point for making the diagnosis in a lot of patients in Ontario. But without it, it's impossible to make an accurate diagnosis without having spirometry to confirm the presence of airflow obstruction. So spirometry is a test that lets us know about a little bit about how airflow is coming through the lungs, and basically you want to see whether or not the airflow is obstructed, which means it takes longer for the person to empty the lungs than it should. Next slide, please. So this slide, the thing I want to highlight here is that your lungs achieve a normal level, sort of their maximum size sometime in your early 20s. And after that, everyone has some decline in lung function as they age. As so many systems in our body tend to decline a bit as we age. But the key factor here is that for people who go on to develop COPD, they have a more rapid decline in lung function, but it's a slow process. So the patient who I see in clinic who may have very severe obstruction and symptoms, that developed over many, many years. That wasn't something that happened overnight. Next slide, please. So this is something we're going to be coming back to over the course of this talk, but we kind of split the management of COPD into these three boxes. So there's the pre-diagnosis period where the patient is having symptoms and may even be having exacerbations and has risk factors that should potentially make them someone who we'd like to be identifying as at risk and testing. But that at this point, often there's misdiagnosis, and sometimes patients will be, treated for sort of bronchitis or pneumonia, and the underlying cause may be missed. Eventually, then there's a diagnosis, which again, without access to spirometry, there's no way to be confident. And I've seen lots of patients where I thought they had COPD. I have a lot of experience treating COPD. It's my main clinical focus, and yet without spirometry, I'm not confident that I can identify a patient who has COPD versus some other airways disease or lung disease. And sometimes, I may say, well, I think this person has COPD, and when I get the spirometry, I discover that I was wrong. So there's really no way without spirometry to be confident in the diagnosis. And so lack of access to spirometry is a real challenge in diagnosing and managing these patients. Then once you've made that diagnosis, you can get into management. And management includes pharmacotherapy, of course, like inhalers, but it also should ideally include other things. Can we go back? I'm not quite done. Should include other things like self-management support and pulmonary rehabilitation. They can help patients to know how to manage their disease and stay healthy and avoid worsening of their disease and avoid exacerbations and things like that. Okay, now we can move on to the next slide. So I just want to give an example. So chronic disease management is a huge part of our healthcare system, and we have success stories that we can look to and we say, well, what would we like to see in COPD? So I wanted to use the example of diabetes to tell a brief story about how chronic disease management can go right in our healthcare system, because I think it's important to have a positive model to work towards. So this is an amalgam of patients I've seen, a sort of a typical presentation you might see, and it sort of presents a best case scenario. So Steve, 25-year-old who has frequent urination, thirst, weight loss, fatigue. These are common early symptoms of someone who's developed type 1 diabetes. He goes to his primary care doctor and has access to diagnostic tests. He can get urine and blood tests done quickly, which are available within 24 hours. So again, the key is having access to diagnostic testing early. blood work shows his blood sugars are high. His doctor calls him. He's feeling unwell and vomiting, so he's recommended to go to the ER for stabilization, and he can receive insulin and other treatment there. Next slide. Once he's feeling better, he has the opportunity to learn about his diagnosis. So his doctor can explain to him about the diagnosis of type 1 diabetes. And importantly, there's an allied health professionals who can help do the next step. So diabetes educator can teach patients how to manage their disease. This is hugely important. When I'm working in the hospital and someone comes in with a new diagnosis, absolutely essential that they see an educator, teach them how to inject their insulin, how to monitor their blood sugars, how to identify dangerously low or high blood sugars, even things like making sure that the physician, be it me or whoever is seeing them, has prescribed the right treatment. I mean, not so much about the insulin, but things like making sure that the physician prescribes testing strips so that the patient can test their blood sugar at home. That's something that's easy to miss if you don't have someone there making sure that things are being done properly. And then on discharge, he can be referred to a diabetes clinic where he sees a physician specialist, but also, again, has access to an allied health team, including educators who can work with him on managing his disease and work with him to help understand how he can stay healthy despite chronic illness. This is a super important point for any chronic disease. It's not just about giving treatment in terms of medications and things, but understanding what the person needs to do to feel comfortable managing their disease and what it means to be healthy despite having that illness. And that can go a long way towards preventing problems down the road. Next slide, please. So the keys here: easy access to testing, rapid identification, access to education about the disease, access to specialists and to allied health professionals. And we know that this, we see this happen all the time in the hospital. I'm obviously, nothing is perfect, but generally speaking, when a patient comes in with a new diagnosis of diabetes, I feel confident that they're going to get the support they need to be successful. And that's because of a diabetes strategy that's in place, because of funding and human resources that have been put in place over time, because of the incentives that exist for diabetes care, and because of the quality standards and evidence-based practice that's followed by specialists and encouraged, by these strategies to ensure that these patients are receiving the support they need and that there's a system in place for them to get the education and treatment they need. Next slide. So now we come to the world of COPD. And again, this is going to be, I'm going to this is an amalgam. This is not one patient, but I want to kind of present the way things the patients I see often, the things that have gone wrong before I see them, and the sort of the path that people often end up following. So John, a 65-year-old man who smokes and has smoked a pack of cigarettes a day for 40 years. He has symptoms of cough and phlegm, which he blames on a smoker's cough and hasn't really sought help for. He develops increased symptoms and goes to a walk-in where he's given antibiotics for quote-unquote bronchitis. So again, often in smokers, these episodes might be an exacerbation of COPD, but if you have not been diagnosed, then that can be missed. Over the next year, he has several more of these episodes with worsening symptoms. So again, if you're having exacerbations, it can be one of the main drivers of worsening disease over time, and it's a missed opportunity to intervene if it's not diagnosed. Next slide. Underdiagnosis is a huge problem. Worldwide, about 70% of COPD patients have not been diagnosed, and the Lung Health Foundation estimates about 1.6 million Canadians are living with COPD and haven't been diagnosed. So this is a very common thing where these patients, just because they're undiagnosed doesn't mean they're not symptomatic. It's often they are having symptoms, they're having progression of their disease, they may even be having exacerbations and hospital admissions, but they're still not being picked up and diagnosed. Next slide. So eventually, he becomes worried about his symptoms and sees his primary care provider. His doctor suspects COPD or asthma, but because spirometry access is difficult, and again, in some regions, this is a big challenge, less so where I work in Hamilton, but you'll hear from our next speaker about regional disparities. So instead of getting confirmatory testing, he's given medication without confirmation of the diagnosis. He also doesn't have an opportunity to see a certified respiratory educator. So unlike the case of diabetes, where diabetes educators are widely available in diabetes clinics and hospitals, and often in family health teams, most patients with COPD do not have access to a certified respiratory educator. Without that, it means that patients often don't really understand all the details about their disease. They don't understand necessarily what to expect, or how to stay healthy. He fills a prescription for his inhalers, but isn't sure how to use them and sometimes misses doses. If people don't understand what the purpose of their medications is, if you don't go through it with them, then poor adherence, not using the medications properly, skipping doses, not knowing how to use the inhaler and using it wrong so that less medication ends up in the lungs. These are all common problems that even patients with severe COPD often face because they don't have access to people who can help teach them how to do things properly, which is a big contrast to what we see in diabetes. Next slide. So unfortunately, his symptoms continue to worsen, and he has multiple hospital admissions over the next year. At this point, he started on home oxygen, and finally, he sees a specialist who confirms his diagnosis with spirometry and adjusts his inhalers. But he still often doesn't have access to an educator and feels frustrated by the gaps in his understanding of his disease. He continues to have frequent exacerbations, often leading to hospital admission. So this is something, again, we see. The diabetes patient who, as soon as they go to hospital, they have access to an educator. For the hospitals that I've worked in, including centers of respiratory care specialization, often there's no access to a respiratory educator for these patients, and they leave without having a chance to understand about their disease. We heard about how COPD is the number 5 leading cause of death in Canada and number 3 worldwide. I often say the example, if you look at the number 1 and number 2 cause of death worldwide, it tends to be cardiovascular disease and cancer. If you go to people on the street and you say, what's cancer, what's heart disease, everyone knows what that is. When you say, what's COPD, many people don't really know what that is. So, despite its outsized impact on hospitalizations and mortality, there's a lack of public understanding. So patients need that education to know what it is they're dealing with. They often go home without really knowing even the name of the disease that they have or even the basic details about what it means for them. Next slide. As you heard, it's a huge burden on the healthcare system. So you can see this chart on the right. Basically, it's just showing you that COPD admissions to hospital have been increasing year on year, even as the overall rate of hospital admissions has been falling. So this is becoming a bigger and bigger problem. And as you heard earlier, it's the number 2 leading cause for hospital admission after giving birth. Of course, we don't want to reduce the incidence of giving birth in hospital, so it's the number 1 preventable reason for admission that we'd like to reduce. Next slide. So back to our patient. John's symptoms continue to worsen. He's not able to attend pulmonary rehab because there's no program close to where he lives. Pulmonary rehab is exercise and education designed for people with chronic lung disease. It was really developed with COPD patients in mind, although it can benefit other patients as well. But access is a huge issue. In general, we see that less than 1% of COPD patients who would benefit from pulmonary rehab are able to access it in any given year. So it's extremely underused. So the patient, as his symptoms progress, it becomes difficult for him to leave the house, and he becomes increasingly anxious. This is something we often see in COPD, where patients are very isolated, have a lot of issues with anxiety and depression and loneliness because they're very limited by their illness. And over the next year, he has increasing hospital admissions, progressively worsening symptoms, and he ends up dying in hospital about 10 years after he first noticed his symptoms. So we see this huge lead time where his symptoms are gradually worsening, but there were multiple opportunities missed to intervene early. And at this point, when his disease is very severe, it's much more difficult to intervene. Next slide. So again, missed opportunities, delayed diagnosis, which is exacerbated by poor access to spirometry, delayed treatment leading to worsening symptoms and disease progression and increased exacerbations, lack of access to disease-specific education, which is a huge factor, and limited access to specialists and pulmonary rehab. So even once we know what's going on, and even when he's having multiple hospital admissions, there isn't the availability of proven interventions like pulmonary rehab that we know can help symptoms, can help reduce exacerbations, but there's not enough access, and so or when there is access, there are major barriers like living far away and things like that that can be difficult for patients to overcome. Next slide. So, what are the keys to improving care? It's the same as for diabetes, essentially. It's not. We don't need to reinvent the wheel. The issue here is the basic tenets of chronic disease management, but unfortunately those are hard for our patients to access. So we need easy access to testing, in this case spirometry, to confirm the diagnosis, rapid identification and access to education about the disease and how to manage it, access to specialists who can help with the more, more severe or more complex components of disease, and access to health professionals for optimizing therapy and support and education over time. Unfortunately, without a COPD strategy, there's been limited investment in health human resources. So access to CREs is limited because they're not widely available and there's no strategy, and that leads to a low number of CREs, which exacerbates the problem. There's limited incentives. I talk to primary care all the time, and it's, as Jess mentioned, it's an absolute crisis right now, which makes it very difficult for them to devote the time and energy that is needed to proper chronic disease management, when so many Ontarians lack a family doctor entirely, and lack of investment in improving access and programs like COPD integrated care pathways. Some of that's underway, but there's still a lot we need to do. Next slide. So just coming back to this, I think there's areas we can work on in all three of these. Pre-diagnosis, identifying patients at risk and getting them tested early so that we don't miss that window to intervene. Making the diagnosis, even once we suspect the diagnosis, it's often difficult to get diagnostic testing. So increasing access to spirometry is key. And then in management, it's not just about pharmacotherapy, but the ability to access education, see specialists, and access things like pulmonary rehab, which make a huge difference. Next slide. I will end there and we'll pass off to Dr. De Zoysa, who's going to talk about the specific challenges in resource-limited areas like Northern Ontario.
Thanks so much, Josh. All right, hello everyone. So as Jess Rogers had also kindly introduced, my name is Mai De Zoysa. I'm a respirologist practicing in Northern Ontario. I'm not sure how many people are from Ontario or familiar with Northern Ontario, and I'm a relatively new transcript. But this is a kind of a diagram of Ontario here. Toronto, or the center of the universe for some people, is down here. And I live in North Bay, and I practice in two places. One's called North Bay, and my main community is a smaller town called Sturgeon Falls, which is in the area called West Nipissing. This might be a little small for some people, but I tried to do like a Google map out of all or most of my patients and where they live. And so many specialists will live in a town and most of their patients come from the same town. In Northern Ontario, we have very few respirologists and patients have to travel hours often to see us. Some of my most northernmost patients come from an area called, or a town called Hearst, and that's about 587 kilometers away from my office. So often they're driving about 6 hours to come and see me. Timmins is another big hub, which is about 360 kilometers away, or a 4-hour drive. When we're looking out west, Elliott Lake is kind of where I have a lot of my most Western patients. That's about a 2.5 or 3-hour drive away from me. And then now I'm seeing patients even south, like closer to Toronto, closer to places like Huntsville. So again, about a 2-hour drive. So I see patients from a very, very large catchment area. And just so people are aware, for this whole big blue area, the dark and light blue, there are 7 respirologists to cover this entire area, most of which are in the lighter blue area, which is kind of northeastern Ontario. And there's only 1 respirologist covering Thunder Bay and that entire northwestern Ontario. Next slide, please. So again, I'm also going to give an example of a patient, and this is actually an actual patient of mine who I reassessed recently. His case is given with permission. This is not actually his picture, though. So Mr. GB was a 60-year-old retired miner. He lives in a town called New Liskeard, which is about an 1.5 hours north of North Bay. He was initially referred by his family doctor in 2019. However, next slide, please. I was on maternity leave at the time, and so I had to unfortunately return the referral back to his family doctor, asking them to re-refer to another specialist. But unfortunately, there was nobody else accepting referrals at that time, and the GP retired shortly thereafter. So unfortunately, Mr. GB became what we call an orphan patient, which essentially does not have a primary healthcare provider. This is happening more and more frequently. He basically then just had to go to walk-in clinics or the emergency department for exacerbations, and was doing this 2 or 3 times a year. Eventually, he was hospitalized for a COPD exacerbation in July of 2022. And one of the physicians he saw in the hospital re-referred him back to my office. And unfortunately, it still took me until February of 2023 to see him because, again, we have such a huge wait list. Next slide, please. At this point now, it has been about 4 years that he's been waiting to see a specialist. He is now 64. He is still smoking, and he does not have a primary care physician. He has limited finances. Unfortunately, he does not have a private drug plan, and he's not yet 65. So he is relying on samples that he's getting from essentially walk-in clinics, and whenever he can afford them, he gets some inhalers to try and keep him hanging on. Next slide. The major barriers that he's having right now is smoking cessation, which is too costly, and he says it's too stressful because basically he's got also undiagnosed mental health issues, including depression and anxiety, and he tells me that it is too stressful for him to quit smoking. He's quite weak in general because he's less active because of his shortness of breath, but there's no access to local pulmonary rehab. There's no access to local respiratory educators to go over things like proper inhaler technique and how to recognize symptoms of an exacerbation when he should be going to see a primary care physician. And unfortunately, to chop this all out, he does not live in the towns that I practice in. He doesn't drive, and so he has difficulty going for appointments. He has to wait for a friend to be available to give him a ride. And it's an hour and a half away from me. So that also delays care because he has to wait for a ride. He has missed appointments. So this again delays things by several months. Next slide. So given that case, I'd like to kind of talk about a bit how COPD outcomes differ across Ontario. So this is, again, a picture predominantly of Southern Ontario, and then Northern Ontario was a little insert in the picture here. And we have geographic local health teams called LHINs. And so the big LHINs in Northern Ontario is the Northeastern LHIN and the Northwestern LHIN. And we'll have multiple LHINs in Southern Ontario, for example, Toronto Central and such. Next slide. So looking at the COPD outcomes, so the numbers here are incidence, or the number of people with COPD. There's 15 out of 1,000 people with COPD in Northern Ontario. Compare that to 5 to 6 out of 1,000 people in Southern Ontario. So there's already, 3 times more number of people with COPD in Northern Ontario compared to Southern Ontario. Next slide. Hospitalization is also higher. So, the next slide. There's 37 out of 1,000 people per year admitted with a COPD exacerbation versus 17 out of 1,000 people. So again, a significant percentage more people who are being hospitalized with COPD. Next slide. And the same thing with emergency department visits. So in Northern Ontario, 52 out of 1,000 people per year are coming to the ER with a COPD exacerbation, compared to 11 out of 1,000 people in Southern Ontario. So again, huge discrepancy in the healthcare burden and morbidity due to COPD. Next slide. So now that we know that, yes, there are definitely measurable differences in COPD resources and outcomes in different regions, so Northern Ontario versus Southern Ontario, why are these COPD outcomes worse? Next slide. So there's many different barriers. Big one is lack of access to primary care. So this is data from the LHIN, which I think is about a year old now. But if you look at the Toronto Central LHIN, there are almost 200 GPs per 100,000 people. And in West Nipissing, or Sturgeon Falls, which is the area that I practice in, there's about 55 GPs per 100,000 people. But essentially, again, multiple magnitudes, fewer GPs in my home region compared to Toronto Central. And when you don't have GPs, again, you're limiting initial diagnosis. They're taking longer to even be told they have COPD before we can move up the chain. Next slide. And when along with the lack of GPs, like I mentioned earlier, there's a lack of respirologists. So respirologists are the people who deal predominantly with the moderate to more severe COPD patients. Again, in the Toronto Central area, there's about 5 respirologists per 100,000 people, and we have Again, 80% less of that in our area, which is the Northeastland. We have 1 respirologist per 1,000 people. This causes increased wait times up to over 12 months. When I was practicing in Sudbury, before I moved to my current region, I had an 18-month wait list within about 6 months of starting practice. This is only getting worse in these areas. And what's happening is, while they're waiting to see me or another specialist in our area, patients are continuing to decline. They're having exacerbations and hospitalizations, and this is causing, again, increased healthcare burden, and it's also causing patients to deteriorate more rapidly before getting optimum care. Next slide. So there are also many other barriers to optimizing COPD care in my region. As mentioned earlier and explained quite well by Dr. Wald, there is limited access to respiratory education resources here as much as there are in bigger centers. So we don't have, certified respiratory educators. We don't have enough RTs and family health teams. We have limited access to pulmonary rehab, though this is improving now, at least in North Bay, because we've just got some funding from the government for this. There's limited access to respiratory testing. So, for example, at the height of the pandemic, when a lot of things were shutting down, in Sudbury, which is our main city in Northern Ontario, the wait list for PFTs came up to about 2 years. And they weren't even accepting referrals from GPs, which is usually the start in terms of diagnosing COPD. There are a lot of smaller communities that have smaller hospitals run by hospitalists, and they'll have probably 1 or 2 respiratory therapists covering their PFT lab. And a lot of those closed down during the height of the pandemic, and they just haven't restarted because they don't have the staffing or the funding for it. So this means that patients in smaller communities, like Elliott Lake or Espanola, for example, have to travel to the nearby bigger towns like Sudbury, which is an hour or 2 hours away, for them to get testing, which of course when you limit the access to testing, you're also limiting diagnosis and optimizing care. We have lack of addictions and mental health support services, which is a huge problem for patients with chronic diseases like COPD. And we've noticed a huge uptake in things like depression, anxiety, of course, during the pandemic, and in our elderly populations, which overlap with the patients that I'm seeing. And if we can't treat people's nicotine addictions and other recreational drug addictions, if we can't treat their depression, anxiety, it is very hard to treat their underlying lung disease. A lot of people are self-treating their mental health issues by smoking a lot or by overusing cannabis, for example, or other recreational drugs. And if we can't treat the underlying issue, we're not going to be able to get people to quit smoking and to get on top of their respiratory health. And then, like I mentioned earlier, there's a large physical distance between Northern Ontario cities and communities. And so you have to be able to drive. And if you don't, you have very limited access to treatment. And not just for respirologists, but also for other specialists. So a lot of the patients who see me also have concomitant heart problems and need to see a cardiologist. And so they're traveling from North Bay to Sudbury, which is an hour and a half to 2 hours away. They might see a rheumatologist, most of whom have to go to Barrie, which is about 2.5, 3 hours away. So they're traveling all over the place, large distances, often having to, take a couple of days, they drive, stay overnight. Like, these things are difficult to manage. And yet, our patients here are quite resilient in doing their best to access care and advocate for themselves. And the other big thing that we have problems with is reduced access to lung transplant. So, when we've maximized all our medical therapy for COPD, and if they meet certain criteria, we say, okay, well, we've done everything we can medically. We should look into whether or not you might be eligible for a lung transplant. And unfortunately, for people in Northern Ontario, as well as many other parts of Canada, this is not as accessible as they are to people in Southern Ontario. People have to be able to relocate to the GTA for some period of time, usually minimum 3 months, if not longer, in the peri-transplant period. They need to have access to a support person to be able to be with them during this whole process. Often on that alone, we have a lot of patients who say, they just can't go through the process because they have no way of getting to Toronto. They have no way of staying there. And there is no funding or support for these kind of patients. So this is often one of the major barriers for getting patients something that otherwise they might be eligible for. Next slide, please. Okay, so knowing all of these barriers, how could we help my patient here with his COPD patient journey? Next slide. So the big things that we're advocating for is expanding respiratory care, things like diagnosis, respiratory therapists and education, pulmonary rehab, and rapid access respiratory clinics for high-risk patients. So for patients especially who have just had an exacerbation or hospitalization, they shouldn't have to wait 6 to 12 months to see a specialist. They should be seeing them within 1 or 2 months at best, and ideally within a few weeks. People should be starting pulmonary rehab within 4 weeks of a hospitalization for COPD. We want to improve access to healthcare resources for smoke cessation, for counseling and psychosocial support, for triple therapy and inhaler, which is basically maximum inhaler therapy for COPD. Because all of these things are not just improving people's quality of life, but it actually improves your lifespan. And so putting people on oxygen, smoke cessation, and maximum inhaler therapy have been found to basically reduce the chance of death in people with COPD. And we should be doing everything that we can to have at least these few things available for our patients. And that's one of the things that we're right now lacking. Now, as people may have heard in the news, there's a new national pharmacare initiative. They've talked about diabetes and contraceptive care as one of the major things that they're bringing up. And as Dr. Walt had mentioned earlier, diabetes is also already one of those chronic diseases where they have better advocacy for it. So similar to making sure patients have access to diabetes medications, I would like to have COPD medications, especially inhaler therapy, added onto that. So nobody has to go without appropriate COPD care because they can't afford their inhalers. And again, this is not just making people less short of breath. This is actually improving people's lifespans. And then the other thing, of course, that's near and dear to my heart is making sure we have more funding and support for rural and Northern Ontario lung transplant candidates. Because right now I'm telling people there's pretty much very limited support to get you to Toronto for your appointments, to be able to stay there. And so we need to have more funding access so that these patients can get the care that they need. Next slide. All right, so those are all major points that I had for today. And hopefully I'll be talking to you a bit later on in the presentation. Thank you.
Thanks so much. Thanks, Maya. So I'm going to ask Scott Bailey to come online. You can stop sharing for a few minutes, Hasna, if that's okay. There's Scott. Hi, Scott.
Hi, everyone.
So we're having some good, I apologize. I had said that the chat is open, but it's actually in the Q&A, but it's good because people are still using that as an opportunity to put their comments in. A lot of what's resonating is the certified respiratory educator and how do we have more people trained up in that space so that we have greater access to it. We wanted to pause here after Josh and Maya gave their kind of perspective using a sort of their experience, but also sort of a patient story or patient stories kind of combined into one. And wanted to check in with Scott here because you're living with it every day. You're linked in with a lot of others that are living with it. And just wanted to allow you some time to kind of tell your story and what's resonating for you, what you want to bring to the forefront.
Thank you, Jess. I appreciate it. Good afternoon, everyone. I am a COPD patient. I'm also advocate and my Lung Health Foundation advocate, and a member of the Lung Health Exercise Program, and a participant in a local program we have here in Belleville called Better Breathers. I have been suffering with COPD for about 10 years that I know of. I find it very difficult some days, mentally as well as physically. Anyways, how I figured this out when I was going on a fishing trip that I go away with every year with my 4 high school friends, and felt great because I had quit smoking 2 years previous to that, and I was paddling around and everything else because we portaged back to this lake, and I proceeded to paddle all day long. And on the way out, later on that day, I fell to the ground because I couldn't catch my breath. Got out, finally felt okay. When I got home, called my doctor, made an appointment. He recommended that I go to the hospital, Joseph Brant, and have a test, spirometry, as well as the breathing test at Joseph Brant Hospital. I'm very lucky to have a doctor and a respirologist here in Burlington, which I know a lot of people don't have that opportunity. And I feel really bad about that because they shouldn't. They shouldn't have a problem finding this information. So one thing that I find very difficult with the government, the medical, is the simple fact that for COPD, there's a lot of things that the government doesn't do. And you've heard all the facts, you've heard all the information, how bad a disease it is, how much money is put into it, how much it's going to cost in the future. The one thing about it, the government doesn't do enough with public information. They don't do enough for money and for the research. They don't do enough spirometry testing. They don't send enough research information out to us that already know that we have it. Would be really nice. There's a few diseases out there, and they get a month to be recognized, such as diabetes, such as heart and stroke, such as cancer. We get 1 day a year globally. We should get a month. We need a month. And I'm just going to end my part with something that I say to a lot of people when they don't understand COPD. I look at them and I say, do you think about breathing? And most of the time they say no. And I say to them, I think about it all the time because I have to. Thanks.
Thanks, Scott. Thank you for those reflections. And I know too that you'll be back when we're starting to talk about the panel, but I appreciate you top lining some of those key pieces from what can we be doing better. And we're already starting to see some themes sort of emerge, right, between what both Josh and I have talked about and then from what you're living as well. So I really appreciate that. Is there anything that you would add in terms of the experience that you've been having in linking in with others that also have chronic lung disease, COPD, and others, or is this similar to in terms of what they're sort of saying that is needed more? What are you hearing? What would you say on behalf of that group?
The exercise group that through Lung Health that I'm involved in, there's a lot of us that we get on a little bit earlier and we sit and talk about things. So it's really nice and it makes you feel better. It's funny though, I've noticed, say out of 20 people that probably 16 are women and only 4 men. And I know there's a lot more men out there that have this issue. And I don't know why that they're not coming on to get exercise. It's a great program and it does help you in the long run. I just find it's the stigmatism with COPD is terrible.
Yeah.
So I don't know what else to tell you on that, but everybody thinks it's just because of smoking, and it's not.
That's right. And even if it was, it shouldn't matter. People deserve the care that they should be getting, right? So, okay, thanks for that, Scott. We're going to transition, and Dawn, Dr. Bowdish is going to talk to us a little bit about her work and kind of long-term care, et cetera. And then we're going to open it up and have lots of time for conversation. So I am monitoring what people are putting in the Q&A area. So thank you for that and keep those ideas coming. Over to you, Dawn.
Thanks so much for having me. And Scott, that was remarkable. In the introduction, they said I was the advocate for research, but I think actually you might be doing a better job than me. So I appreciate that. Today, I'm going to tell you a little bit about long-term care. I've been studying the health of older adults in long-term care for a long time, and I want to share some unique perspectives about COPD and long-term care. Next slide, please. Canada's long-term care sector is extremely problematic. Unlike most European countries and many other countries in the OECD, our long-term care system is not really part of our healthcare system in a real way. And you can see that across the country, we have a big mix of for-profit, non-for-profit, and publicly owned healthcare systems. And what this means is there's a real challenge in setting standards and monitoring for the health of people who are living in long-term care homes, with different provinces making decisions about when to inspect homes, what's an acceptable level of health conditions, what sort of vaccination strategies will they take. And Canada has a real problem. And I think the next slide will illustrate this. This applies to the COVID pandemic, but honestly, it applies very much to COPD. Because of our mixed healthcare, our long-term care sector, and because of the lack of systemic regulation, we have the shameful title of having had the most deaths due to COVID in long-term care of all the other OECD countries. And if you look at how much we surpass those other countries, I think you'll see that this is a huge problem. Many of the issues of the COVID pandemic are also issues for COPD care for people living in the long-term care. And I can think of no better way of illustrating our failures in using this pandemic to change the long-term care sector as I can in the next slide. We have systemic issues with the way that we build our long-term cares, the way that the number of people we put in a room in long-term care, the way we staff long-term care, which meant even prior to the pandemic, we used to have more deaths due to respiratory infections than other countries. This is a graph looking at the number of outbreaks in long-term care and retirement homes. You can see the pre-pandemic years before 2020. And despite the fact that we had a brief moment, a little window in time where we had the public's and policymakers' attentions about the structural challenges with long-term care that needed to be changed, we have lost that momentum in fundamentally fixing our long-term care sector. And so now the number of COVID outbreaks continue to dwarf the number of outbreaks even in the pre-pandemic times. How does this apply to COPD? Well, COPD exacerbations are often triggered by respiratory infections. And respiratory infections are something that we often sort of have this fatalistic attitude about, that, oh, well, people are older, they have comorbidities, they're just going to get sick. I'm an immunologist. Nobody loves a vaccine more than I do, but I acknowledge that vaccines are the last step in protection, in preventing infections. And systemic changes like fixing air quality, fixing rules about how we treat infectious disease, educating people and providing the care they need within the homes helps prevent these infections. Can I have the next slide, please? I would like to tell you a story about sort of a composite woman of the people that I had the privilege of serving during the COVID pandemic. Now, long-term care is something many of us have really mixed feelings about, and we choose not to think about it when we're young, and when we need it, we worry a lot about this. So many people with COPD struggle about the idea of moving to long-term care. Now, this composite person who's wanting to get to move or needing to move to long-term care because she's lonely, her partner's died, she's on her own, she's struggling, her world is getting smaller and smaller because her COPD is such that she's getting nervous about going outdoors, especially in the winter when it's slippery. She may have had a fall or been hospitalized. She just finally makes the big decision to move into a long care community, and she moves because she's sort of sold that this would be really a good thing for her and her health. She's told that there are really great exercise programs in this home that she can attend. She's told that her medical care will be a priority and somebody will take her COPD seriously. She's often been told that the anxiety she feels when she's short of breath is a mental health concern instead of a lung concern. And she's also lonely, and your world shrinks when you're living with COPD and you're older and you've lost friends and partners. And so she likes the idea of meeting a community of people like her who she can spend her final years with. Now, she gets to the home and the experience is not what she thought it would be. She tries the exercise program. She immediately feels short of breath, and she realized that the young person who's in charge of it has no training or experience in respiratory health and COPD. So she realizes that this is not something she's going to be doing. We have a crisis of, again, conflating really true mental health issues with the anxiety that comes with not being able to breathe. We have a huge overprescription of antipsychotics in long-term care. And, you know, I think this is always, I know we've had some great comments by the respiratory educators. And so I'm sure many of you have used the tool of trying to teach someone what COPD feels like by asking them to breathe through a really small straw. And whenever I've done this or I see someone doing this, one of the things I'm really struck by is how panicky people look. Their eyes are huge. They're looking all around. They're nervous. It's scary when you can't breathe. When you can't breathe, you will feel anxious. And unfortunately, without really good diagnostics, oftentimes these two things are conflated. Many of our homes, especially in the province of Ontario, may have 150 people living in them. Of those 150 people, at least 20% of them have COPD, and it could be as much as 40%. And yet, you would think that those numbers alone would warrant access to a respiratory educator or a respiratory therapist, and that is simply not the case. Most of the people will never get to meet one of these people unless possibly they're hospitalized. Similarly, remember all those outbreaks I showed you? Well, those have real impacts in both healthcare, but also the socialization and that mobility, which is so important in older adults. When outbreaks are ongoing, many people have their mobility curtailed. And so what ends up happening with people like this composite long-term care resident is that there's an escalation of care that happens really quickly. So instead of dealing with that in COPD, you get this terrible cycle of more and more issues. And another challenge is because there are so many infections in long-term care, there's a repeat antibiotic prescriptions quite frequently, which can have a real problem if some of these homes deal with antimicrobial resistant pathogens. So the reality and the hopes do not match in long-term care. Can I have the next slide, please? And it is essential to prevent those first exacerbations. We know that once somebody goes to the hospital for their first COPD exacerbation, their trajectory is grim. We also know that the biggest predictor of whether you're going to go to the hospital for COPD is having already been to the hospital. And we also know that the number one reason people from long-term care get transferred to the hospital is because of a COPD exacerbation. And yet we have this spectacular tool in our repertoire, vaccinations, which are not reaching people who need them. And just as we heard about that magic year, 64, you have to pay yourself, 65, you can have this paid for you. We have some of our adult vaccinations fall into that category. And I am shocked to share with you that of people who have COPD who are less than 65 years old, less than 30% have had all the recommended vaccines, less than 30%. This is a tool we have to prevent those exacerbations, which is not being used. Next slide, please. So what happens after you're hospitalized? Well, the older you get, the less likely you are to return to the life you once had. We've heard about deconditioning, and we've heard about all the other challenges. Hospitalization is associated with what we call increased medical complexity. So once you've had one of these exacerbations, your chances of having a heart attack, having your lung issues exacerbated, some of the medications are associated with metabolic issues. And this leads to this two-pronged problem. So now we have people who are increasingly complex and need more time from a family practice and from specialists. And we all know we can't absorb that. And then they also, if they're going back to the home, they need maybe increased health needs. And so what ends up happening is if there is not a space in a long-term care for somebody because they have this increased medical intensity, they end up staying in the hospital for a really long time. And we know that the longer you're in the hospital, the higher the chance you have of having deconditioning and all these other health issues. And this leads to this incredible cycle of the beds being full but not being able to release people because they can't get that care they need. It is an ongoing and very real problem. Next slide, please. So what do we need? Well, we need to improve the structural features in long-term care. And I will also remind you that a lot of the cleaning air that we need to prevent infections also cleans up all that particulate matter that comes with wildfire smoke. I'm sorry to say, but last summer's wildfires are going to be the rule and not the exception as we move into a warmer future. And you will have heard all over the news that people who have COPD and heart issues are the ones who are most likely. So fixing these structural issues for viral infections will also have this add-on benefit of cleaning up the air quality for people living with these health conditions. We also need to get smart about using our vaccination properly and forgetting the magic year 65. It doesn't make any biological sense. We also need to get access to these respiratory educators, to exercise programs that suit the needs of the people who need them, and to therapists in the long-term care and retirement home setting. There is a massive unmet need, but because we separate this from healthcare, there's really not very many mechanisms to get those into place. And I believe that's the end of my slides, but could I have the next slide, please? Yes, so that's the end of my comments there. Thank you so much.
Thank you so much, Dawn. So we can, let's stop sharing for a few minutes. Everyone come up on screen and off mute. There's just been like a whole bunch of new things coming into the Q&A, so I've been trying to moderate that. And so those that aren't in that space right now, if you are at your computer or your phone and you click on the Q&A piece, you can see there's been a lot of really good discussion, including our panelists in there answering questions and providing additional perspective. So I really appreciate that, Josh and Maya, and Scott even as well. So as Dawn's been talking. So we're going to talk a little bit more concretely in terms of Lung Health Foundation, our actual asks kind of going forward. But I wanted to start with the group first and just check in with you, because while we've been working together on obviously preparing this, as you listen to each other kind of go through this, are there pieces that immediately kind of come up for you that you would sort of say underline? I mean, Dawn, I think you did a great job in terms of immunizations, which we sort of, in the health system, we kind of know, but it's one of those things where it can easily be dismissed, to your point, when in actuality, when you look at the research there, it's going to have a huge impact. So that's a good piece of it. But just opening up to the group to see what your thoughts are, just in reflection.
Yeah. Thanks, Jess. I think there's been lots of great comments in the Q&A as well, which has been really gratifying to see. And as you said, I've been trying to kind of type some answers as we go, but I'm sure there's lots that I haven't gotten to. I find it interesting because as I had mentioned, I'm so immersed in COPD care. It's my primary clinical focus. I do research and other things associated with it. And yet, hearing the stories from Maya and Dawn, I realize there's whole huge swaths of the population being impacted by COPD that I don't know that much about. I don't work in Northern Ontario. I don't see patients from long-term care very often because they don't usually come to my clinic, which is the main place that I see patients. And so, it just highlights, how widespread this issue is and how difficult it is to realize the whole scope of it from any one individual spot.
Yeah, thanks for that reflection, Josh. Anything else?
I was really moved by Scott's story about how he was getting a community through his exercise program, because that's one thing I hear from the people both at the Firestone, who I've had the pleasure of meeting who go through our respiratory rehab program, but also in the long-term care community. Like people, your world can get really, really small if you're too, if you can't go out and live the life you have. And so I was really moved by that idea that Scott, you were getting part of your community. And I'm sure you're an incredible asset to that community with some really good stories to tell.
Yeah, for sure. And I think so.
There was a lady that asked a question just a few minutes ago about where she could find it. She lives in Aurora and she wanted to find out more about the lung health exercise program. And I just sent her back saying, look on the website, you should be able to go. This Monday coming, you can get an email and look on it, and they're registering for the newest program coming up. And it's great. It's twice a week. It's lots of fun. You get to meet other people and listen to their issues and what's going on with their lives. So it's pretty good in that respect. So thank you very much, Dawn.
Thanks, Scott. Look at Scott's plugging away. So if you are interested, info@lunghealth.ca is also another way that Diana and Marissa will get back to folks. And the majority of that program is actually part of the funding that we receive from Ministry of Health, long-term care. So we're able to offer that right now, sort of free and open for people. So that's great. And it sort of brings me to some of the chat that's in there for those that are maybe not following along as closely. Let's break it down a little bit, because one of the areas that Lung Health Foundation is definitely advocating in is the space around spirometry. And there's some really good, important comments there that I think would be great for you guys to reflect on, which is this isn't just about access to spirometry. I think, Maya, one of the first things I learned from you was spirometry access isn't necessarily as big of an issue in certain areas of Northern Ontario, but it is in other places. It's not just about the access, it's about the people being able to do it. Do you have the health human resources? How is that information coming back? And then what impact does that have in terms of patient education and also changes to treatment regimen? So I wonder if we could spend a few minutes just talking about, from sort of a policy or what needs to change in that space, what is it about spirometry? There's a lot of work that's been done nationally through Choosing Wisely. I know Ontario Health, who's on the call today as well, it is an area that they are looking at more closely. But What are your kind of collective thoughts around that? Scott, you talked a little bit about spirometry and said that's an area that, we really need to be focusing on.
Yeah, so we definitely need better access to respiratory testing. So for example, one of the background for my training is actually training the Firestone too for respirology. So when I graduated and moved up to Northern Ontario, it was night and day in terms of the access that I had for testing. So for example, like at the Firestone, a lot of our patients coming in through clinics got spirometry. And so I saw them and I had their testing and I had a lot of information at the same time. Whereas now I have to try and coordinate them to get their testing done in a different hospital before they come and see me. Often when they're feeling unwell, they, can't go and, get assessed. We're delaying testing. So sometimes it can get delayed for a long time. And that's, for the places like in real hospitals where they're doing it in PFT labs. There's also not probably as much as we probably see in Southern Ontario, but we are seeing, spirometry that's done in offices and clinics and in primary care. And as I was kind of talking to one of the people in the chat about this too, the quality of the spirometry can be variable depending on, who's doing it, if they have the training for it, if they have the experience to do the testing appropriately. So sometimes if, it's someone who doesn't have the best experience in doing spirometry, you may not get the best results. And if we don't get appropriate results, that can help delay the appropriate diagnosis. So these are, people are trying to do their best to get testing, but it has to be done correctly. So we do need, funding and infrastructure to get the appropriate people doing them. So RTs, CREs, et cetera. And I know there's a lot of different ways that they're looking into that. So trying to access more CREs, like for the hospitals, looking at working more in the primary care setting. So things like Best Care for COPD, which is a program more in Southern Ontario, which they're moving up north, where they're trying to get more CREs and spirometry testing in primary care health teams to kind of get patients better diagnosed and optimized in primary care before they end up seeing a respirologist. It's a great program, but it does still, unfortunately, limit orphan patients' access. So a lot of people are just going through urgent cares without primary care. So it does, unfortunately, not address those patients. That's still a big gap.
Yeah.
And we have patients in, like I said, smaller communities where the PFT lab is closed because it was one RT, which they ended up moving out of town, or they had to be repurposed somewhere else in the hospital during the pandemic, and so those patients just don't have access.
Yeah,
So
I think
there's lots of things there.
Yeah,
I think that's a really good point, Maya, about that. It sort of again comes back to that health resources. Like a spirometer is not a difficult thing to obtain. It's not very expensive. The reason spirometry is harder to obtain than an ECG or blood work is not because the spirometers are difficult. It's because you need someone who knows how to administer the test. And that's the challenge. And I think, I think trying to do it like, and I've heard this from primary care before, if they don't feel like they would be able to just like get one in and start testing, right? Like it's not in their scope. It's not something they're super comfortable with. I think, it's about how do you get people who are able to do this test properly into the spaces, and like you said, like, can it be done in primary care? Can it be done, for orphan patients? Like having it available at a hospital is great, but limits access for lots of folks for lots of different reasons.
And it's also not just doing the spirometry. Oh, sorry. It's also just someone interpreting the results. So, for example, when I was practicing in Sudbury, we had some GPs who were doing spirometry in their clinics, like in their health teams, but a respirologist wasn't interpreting it. It was the family physicians who were interpreting it, and so they're not always up to date with the changes in, spirometry interpretation and ATS guidelines and all that stuff. So, sometimes they would have difficulty also interpreting, what the results are. And so I'd get, family doctors sending me stuff saying like, hey, we got this in the office. What do you think? And so that's sometimes also a bit of a barrier. And again, this is probably more in a bigger city where we have more family health teams and we have more people doing spirometry. But yeah, you're right, Josh. The two main issues is getting it done properly with all the healthcare resources around it, and then making sure it's interpreted properly too. Sorry, Scott.
I just wanted to say, even my doctor's office has a lady there and a nurse, a practitioner, whatever, that actually gives the test. She has one in the office. So before we get that, then we go, to the hospital and do the big test. But until we get, but I believe the squeaky wheel gets the grease. And then until we get a month where everybody sees this and starts coming to everyone about COPD and getting more awareness out there from the government, maybe that's how we get more money for you. And then we expand everything in that case. It's that old story, the squeaky wheel, and I think we have to do something about it.
Yeah. Thank you for those thoughts. And it's certainly consistent with what we're seeing across the chat, which I was trying to also get caught up so that when you guys go back on there, you're not inundated with a whole bunch of comments. So that's spirometry, and that's certainly an area that we're focused in as Lung Health Foundation, most definitely. Let's talk a little bit about the Health Human Resources, and certified respiratory educators are coming up a lot. I think I'd be remiss, this isn't just in Ontario. We are national, and we're hearing from some other jurisdictions in terms of what it looks like for them, what vaccinations are covered, which is great. So please keep that information coming in. I will speak to Ontario only because as part of the work that we're doing, we are partnered with Ontario Health. And so there is more of a concerted effort around what they're calling an integrated care pathway, which is essentially looking across that continuum that we've just talked about and, trying to aim in certain areas and see what we can do. And so you'll see some comments there talking about that. But when we're talking about certified respiratory educators, there's some really good examples of programs that are out there already running. But again, it's very a bit sort of patchwork quilt in some respects, right? It's not necessarily coming from the system down. And I think if you think about, each of you have talked about where that education, that self-management, and it's also about supporting people in their pharmacotherapy management as well, right? So people are talking about, how come we're not talking about spacers and rinsing your mouth out afterwards? And those are all patient preferences that might seem trivial to someone in the health system, thinking, I forgot to talk to them about that. But it is actually something that really affects them. So talk to us a bit about this. Maybe Josh, I'll start with you, because I know we've had really good conversations about, even in the area that you're in, some of those barriers that are there. And then maybe Dawn, a little bit around kind of how do you advocate for something when we don't have enough of them anyway? So even if you had the funding available for more series, there's a lot that has to happen in order to be able to support that workforce. Josh, over to you first.
Thanks. Yeah, I think, as you said, I feel like I'm coming from the position of relative privilege, in a big center that has sort of a focus in respiratory care, and yet still, despite that, it does often feel like a bit of an orphan disease, despite how common it actually is. So I think that's the challenge is and I just, compared to, you think about any chronic disease, I see these patients who have been in the hospital multiple times or been in the emerge multiple times, who don't really know what COPD is, what it means, what they can do to make their health better. I think I saw some comments in the chat, a number of people highlighting, inhaler, not using inhalers properly, right? They're not always easy. Like there's lots of ways that people can make errors that reduce the amount of medication that gets to their lungs, or even that they're getting no medication into their lungs. And I see that so often, and that, that's so frustrating, because it's such a, it's a challenge. It can be tough because as a population, right, COPD patients are disadvantaged in lots of ways. As Scott had mentioned, there's stigma. A lot of people who suffer from COPD have lower socioeconomic status, less income, and unstable housing, other drug addiction issues, mental health challenges. COPD is more common in all of those groups. So you're often dealing with people who maybe their health literacy is a little bit lower than the what some other folks have. Maybe they need a little more support, maybe they need a little more time, and unfortunately, with the strain on the healthcare system right now, when they come into the emerge, when they're in the hospital, very difficult for them to get that. That's something I've been working on in our hospital here, but it is a sort of a drop in the bucket. It's the patients who happen to be admitted at one hospital, and hopefully we get them into our pathway, and they see our nurse practitioner, and they get sent to our discharge clinic, where we have an educator who can spend time with them. But it's often it's a very late very downstream, right? It's after they've already been admitted to hospital. Often it's after they've already been admitted multiple times before we see them, and then you see all those missed opportunities. So if it was something that was more prevalent, if you had those educators available earlier in their course, I think it would make a big difference, because we know that every exacerbation, that there's a risk of death, that there's a risk of deterioration in their lung condition, that it increases their risk of the next exacerbation, sort of the snowball picking up steam as it goes downhill.
Right. The gaining size and speed, you don't have control over it. Dawn, thoughts to you and then others?
Yeah, well, systems problems are big, difficult problems that take time. Even if we could magically get the funding to train more people now, and then we have a distribution issue. We have to get people to the north. We have to get people to these other communities. And so we have to think really strategically about a 5-year plan and a 10-year plan and put those resources into those. One of the things we also really struggle with is good data to help policymakers make these decisions. So Canada's got a sort of a strange healthcare system in that the provinces run it. We don't have a lot of, we don't have a federated system like some countries. And, one of the things we really learned in the pandemic is that there are some countries that their healthcare system and their research systems are so intertwined that they can get good data fast to help make important clinical decisions. Canada is not one of those countries. Whenever I am looking for the best quality data on, which vaccine causes the most COPD, we go to Scandinavian countries, we go to Israel, we go to the English system, because they have that integrated right into their health system. And so without those data, when we tell policymakers, COPD exacerbations are a big problem, we should do these things to stop them, they're like, show me the data. And so there's a terrible cycle. And I'll just use RSV as an example. RSV infections are in countries that have good healthcare systems and do a lot of testing, because the other issue is a lot of adults, when they come to the hospital with their exacerbation, there's no testing to figure out what virus is triggering that. Big centers like ours might have that, but many places don't, because the treatment's effectively the same. It doesn't really matter what virus it is. So Canada doesn't have Canadian data on how bad RSV is. We have to go to other countries that show if you go to the hospital with an RSV, you're really likely to have a high chance of a heart attack the next year. Yet when we go to policymakers and say, you need to expand access to this vaccine to older adults, they're saying, well, show us the Canadian data. So this is where research is so important, because we need this specific case to help to, I acknowledge that healthcare funding is limited. It is not an unlimited resource, and we have to make strategic decisions about where best to put it. But we do so much of the decision making based on a lack of data. And just because we haven't discovered something doesn't mean it doesn't exist. And so we really need to have those systems in place to help our policymakers make the best decision.
Yeah, absolutely. That's great. And so
Can I say?
Yeah, go ahead, Scott, please. Yep.
I think the patients have to advocate more for themselves in today's medical society, because it just doesn't happen otherwise. And I'm looking at the doctors on the screen here, and they're all shaking their head yes. So I just think it's well worthwhile to advocate for yourself more and to say more things and ask more questions.
Scott, just on that point, what's sort of your advice back to organizations like ours who are working with, trying to advocate on patients' behalf and caregivers' behalf? We have a few caregivers here talking about just how challenging that is for them too, in terms of helping family members or friends navigate the system. But what would you like to see, Scott? Because it's individuals for sure, but is there more that we can do to support individuals to feel empowered to advocate for themselves?
That's what we need, is support. Big time. It's very difficult for us that have COPD to do a lot, because most of us don't know what direction to go in to fight this or to help the cause. If I had zillions of dollars, I'd help Maya here in North Bay. She needs help. It's just ridiculous to me that in our society we have to beg, borrow, and plead to get people to help other people.
Yeah.
So that's my.
Unless there's I just wanted to remember something I wanted to bring up as well. There have been some great comments in the chat about virtual care, which I kind of forgot to touch base on during my chat. And it's like Josh had mentioned earlier, Dr. Wald had mentioned earlier, we definitely have more access to it, which is great. Like we can now, do some telephone assessments. We can do more virtual assessments rather than just OTN. But we still have a big barrier that also needs to be addressed in terms of making this more accessible to patients. So my patients often are, they're elderly, they're not as tech savvy. They live all over, Northern Ontario. Access to even a functioning phone is sometimes intermittent. Cell phone reception is poor. They don't know how to check their voicemail messages. Internet is spotty. And I have a lot of patients who have difficulty connecting with me because they have difficulty accessing virtual care. And the rules, have changed in terms of what we can do and can't do in terms of virtual care too. It's not as good as it was now, or not as free as it was back in the worst of the pandemic. But somebody had mentioned in the chat about OTN, which is a great resource, for patients, but there's still a lot of barriers. First of all, it is a bit of a janky system at best. It is very hard for physicians to be able to, log in that system, like send the links, like it's very difficult. And, as a result, there's a lot of, time wasted trying to get on the system. It's not working half the time. The system shuts down. We're wasting time, where we could see more and more patients unless we're struggling for 20 minutes trying to get this thing work. And of course, patients have to go to a center that does OTN to be able to access that. So I have, for example, personally in my practice, I've kind of done less OTN because it's such a difficult thing in my practice to kind of keep on. And again, time is patience. The more time I'm dealing, struggling with one program, I could have seen 2 or 3 other people. So I use other video platforms like Zoom, which are a little bit more user friendly. But even then, I can't tell you how many times I am, on the phone while on Zoom trying to figure out, telling them like, there's a button on the bottom, press that button. It's so time consuming, and patients also get quite frustrated. And they're like, why can't you just do this on the phone? I'm like, I can't, because the government tells me I have to, either see you in person or get another referral to see you virtually. Like the rules are still a little bit not user friendly. So I mean, there's a lot of stuff that we're still struggling with. So it's not like I can just give you a call, and even if I did, I'm not getting the best care too. So it's very, very problematic for patients, especially in our more rural areas, to try and get the best care.
Yeah, thanks for that, Maya. I'm looking at time. I've given Huston a sense. I'm gonna bring up our closing out slides here, but I appreciate that because it's not just rural in terms of Northern Ontario. You have small rural communities across Canada. Even within Ontario, there's other pockets where a lot of those barriers are faced. And I think it really speaks overall to the diabetes example, Josh, that you brought forward. In Ontario, certainly, and in other jurisdictions, that all started with a strategy, right? It actually became a strategy. And within that, there are a lot of different pieces that were being looked at. In Ontario now, there's this integrated care pathway for COPD. And so looking at some of those incentives, Maya, you just started to talk about. And I don't mean incentives in terms of pay, but it's also, ensuring that those things are in place for both providers and people living with lung disease to be able to kind of navigate and access. I think one of the other areas that's a good conversation for us to keep going as we continue beyond this forum, and perhaps an additional forum, is really talking about pharmacare. So now that that's sort of top of mind, Maya, you brought it up quite rightly. When we look at the therapies and access to the drugs and availability of the drugs for people in terms of being able to afford it, that's a huge piece that I think as Lung Health Foundation we can bring back to the table, because it affects all people regardless if it's COPD or other lung health issues. So I want to thank everyone for those comments. We have really great things happening in the chat, and so I'll encourage Josh, Maya, and Dawn, and Scott to take a look at that and see if there's anything I've missed in terms of follow-up there. I want to stop, sort of end by talking about what we can do, because this webinar was not intended to become, come get informed for sure, but it's also, hopefully you're equally inspired, I will say, as we are in terms of doing more together. And so if we go to the next slide, the Lung Health Foundation, sort of this continuum of care, we are looking across it to say, where can we lend support? Where can we shine a light in terms of areas that we want to focus on? Next slide. We will be sending these out to people so you'll be able to refer back to them. I'm not going to go through all of it because you've heard some of this, but I wanted to give you a good sense of, as an organization, we're not just having these conversations. These are the things we're actually bringing forward and talking about. And so that's why all the comments you've made today are really critical for us, because then we can say, here's what people are talking about. Healthcare professionals, people in the system, provider, patients, as well as the caregivers. So promoting public awareness, we really need to determine how can we better engage not just primary care providers, because we know what that system looks like. We have to look elsewhere. There's a lot of good stuff happening with paramedics and pharmacists in terms of their scope of practice increasing, et cetera. And so we have to really think, I'm not going to say outside the box. I think we just have to look at the reality that we're in terms of where people are going and where those trusted relationships are. Next slide. We've talked a lot about spirometry, so know that that is an area of focus for us, both in terms of diagnosis, but also during management of someone with COPD. There is an important role that spirometry plays throughout that continuum. Next slide. And then when we talk about what happens around management, so we are raising awareness around, there's changes to the pharmacotherapy, so prescribing the drugs available for COPD and what standard of care should look like. Maya spoke a little bit to that. This is where we're talking a lot about CREs and the self-management support. So that's pulmonary rehab. You've heard us talk about exercise programming, self-management supports that CREs provide, and some of the great programs, not just that Lung Health Foundation is offering, but others as well in those pockets. And so what role can we play to bring all of that together so we're one-stop shop? You can come to us and say, what's happening in my area? What might already be there? What might Lung Health Foundation be able to provide in terms of some of these supports? So more to come on that. And as I conclude, the final slide here, next slide, Hasna. This one. There are 3 actions for each of you today that I'm hoping are like a little bit more tangible as opposed to taking on the whole system. We want you to help us take on the whole system by doing 3 things. To stay connected with us, so you can join our network. You'll get an email that asks you if you would like to be that. It was on the registration form as well, but we'll send another email out. That just means you're connected through monthly newsletters, but they're really activated. So it's like, hey, join us on this. Follow us on social media, because it's a really great way, whatever social media platform you're on, to follow us, because then you're really in the know of what's going on. You can become an advocate, share the session once it's posted to help raise that awareness. And of course, benefit from the programs and resources that we have available for you. They're freely available. You've heard about some of the programs, but there's also good content on our website. If you want to advocate for yourself, there's great tools you can bring to your healthcare professional and say, I think I need this. I think this is something we should be talking about. So as always, we are here for you. info@lunghealth.ca is where you go. On behalf of our sponsors, on behalf of the Lung Health Foundation, on behalf of everyone we serve, I really want to extend my thanks to the panelists, Dr. Wald, Scott, Dr. Bowdish, and Dr. de Souza. So thank you again, everyone, and have a wonderful rest of your day.